Okay, so thank you, Dr. Vinay, for the nice introduction. And it's a pleasure to be part of this instruction course. So I'll be talking about the tips and tricks for AGV implantation. And as has been said, it's the most common implantation being done in India. And tube implants now are a viable option for management of glaucoma. They are gaining popularity because of the better designs which we have, material and techniques, and significantly improved long-term outcomes. So they're majorly being used as a primary choice in secondary complex glaucomas. However, with the results of TVT in place, its use is increasing even in primary glaucomas. For any incisional glaucoma surgery, it is very, very important to have a careful assessment of the patient before surgery. And incisional glaucoma surgery, as we know, is all about conjunctiva. So for any incisional surgery, we need to select the quadrant which has the least scarring. For AGVs or any implant, the superior temporal quadrant is the most preferred one because of the ease of surgery and the lower incidence of ocular motility disorders, and cosmetically also it is the best quadrant. Be prepared to use autologous and exogenous graft in case it is needed. For any implant, it is very, very important that you have a proper placement of tube, which is critical for better long-term outcomes. And for that, again, you need to do a thorough preoperative workup to know the extent of PAS and the status of lens. Both these factors are very important determinants for the position of the tube. If the patient is having 360-degree PAS, then you cannot put the tube in the anterior chamber, and you have to go for either a sulcus placement or the placement in vitreous. And the lens, the phakic and pseudophakic status are also important to determine the position of the tube. Also, since most of these patients are having associated comorbidities, so it is very crucial to know about the other comorbidities. If there is any vitreous or blood or excessive inflammation in the anterior chamber, then you have to first correct these factors, otherwise it can lead to blockage of the tube. Doing AGV is very, very simple in as a routine case, and is much more simpler than doing a non-valved implant, because you're just dealing with one quadrant. You are not handling the muscles. And it's very, very important to have a good exposure, because you are going to fix your plate 9 to 10 millimeters away from the limbus. So the corneal traction suture, I generally tend to give both, especially if the eye is small. And these radial relaxing incisions are very, very important, because you need to dissect the conjunctiva till deep into the fornix. And one needs to dissect it, go right up to the equator. And a gentle cautery, it is very, very important to mark the site where you are going to fix the plate. And it is generally 9 to 10 millimeter when it is superior temporal. And the priming of the tube is very, very important, and you should get this smooth stream of fluid come out to check the patency of the tube. And then don't hold the AGV through a valve, otherwise it can damage the valve. As far as suturing is concerned, you can use any non-absorbable suture. So one single 9/0 nylon suture can be used for the fixation of the plate and the tube and the scleral patch graft. So you give these sutures to fix the plate. Here, 9/0 nylon. You can use any other non-absorbable suture also. And it's very, very important that you are sure that you are not you're not very close to the muscle. Although in AGV this problem is not so much, because this the plate is not it doesn't touch the muscles. Now the placement of the tube is very, very important. You have to mark the site of the placement of the tube also, and this I just make a small bed for the tube, so that the tube, you can fix the tube well here and just cauterize it. And the length of the tube, again, if you want to place it in the anterior chamber, it should come 2 to 3 millimeter inside the chamber, and you have to cut the tube bevel up and just enter it, the parallel to the plane of the iris here. Just inject a little bit of visco into the track also, just so as to make a smooth entry of the tube inside the anterior chamber. This patient didn't have any PAS, so the placement of the tube was done in the anterior chamber. And then the fixation of tube again with the same 9/0 nylon suture. So this is a box suture. It is very, very important that you fix the tube properly so as to avoid the movement of the tube and the extrusion. And then there's the scleral patch graft. You can get this is the rim, corneoscleral rim, which is available in our eye bank. So you can either take a sclera or a cornea or a part of sclera and cornea, whatever you feel. So again, with the box suture, you just cover the tube with this the patch graft. And it's very, very important to cover the tube in its anterior part because so as to prevent the extrusion. And finally, you have to do a watertight closure of conjunctiva. So at the end of surgery, you have to make sure that the tube is in place. It is neither touching the cornea nor iris, and the pressure is nicely maintained. It's a normal pressure at the end of surgery. You can even if you don't have the availability of the patch graft, then you can make a scleral flap the way you do it for your trab, and insert the tube under this scleral patch, under this scleral flap. It is not always, as I said, possible to insert the tube in the anterior chamber. This patient was having neovascular glaucoma with 360-degree PAS and dilated pupil with ectropy on UVA, as you can see, and you can easily put this tube, since the patient is pseudophakic, so you can easily put the tube in the sulcus. However, the distance from the limbus, I think you should mark it. It is slightly more when you are putting the tube in the sulcus as compared to when you are putting the tube in the anterior chamber. So it is around 1.5 millimeter as opposed to 1 millimeter when you are introducing it in sulcus. And this is pars plana. So you can insert the tube in the pars plana also, if especially in patients who have undergone VR surgery, or you can do it in patients when you're performing a triple procedure with pars plana vitrectomy, because a complete vitrectomy is essential when you have decided to put the tube in the vitreous. So 3.5 millimeter away from the limbus, and cut the tube. Here the tube should be visible post-operatively through the pupillary area. So the length of the tube should be more, around 5 to 6 millimeter from the limbus. So it should be visible, and you can use a pars plana AGV with pars plana clip, or you can use the routine AGV also, FP7, for this purpose if you don't have the availability of pars plana AGV with pars plana clip. So this was the routine AGV which was used here in this case. Only thing, when you use pars plana clip, then the direction is more straight as compared to this routine one. Sometimes you do get problems on table when there is extensive PAS and it is not possible to put the tube in the sulcus also. This patient was a traumatic glaucoma patient with the ACIOL being put in the posterior chamber, and there was a rent which was seen, and one failed trab. So it was not possible to, you can see here there was a lot of PAS. So what you can do is just make another port and try to release this PAS with iris repositor. So here you can, with little bit manipulations, you can put the tube in the anterior chamber. So a little bit of manipulation on table can make the surgery successful. AGV can easily be done with the phaco. It can be combined. The last session, they talked about the combined phaco trap, and especially in secondary glaucomas, it is a very good choice to do phaco tube rather than phaco trap, because the success rate of phaco tube are much better. So you can do a cataract surgery first, and then the tube implantation as you do superior-temporally as a routine. This patient had 270-degree anterior ciliary staphyloma. Only nasal quadrant was free of staphyloma. So you have to choose a quadrant which has minimal scarring and which is free of any comorbidity. And the advantage of combining it with phaco is that you can put the tube in sulcus if you have a slightly dilated pupil preoperatively. If the pupil is small, then you have to be very, very careful that the length of the tube is large enough that it doesn't get obstructed by the iris post-operatively. So post-operatively, as in any other glaucoma surgery, you have to use steroids for 8 to 12 weeks, antibiotics, cycloplegics, and it is very, very important in AGV to monitor intraocular pressure, because the hypertensive phase is very commonly seen. Maybe up to 70 to 80% of the patients do encounter hypertensive phase. And the studies have suggested that if the pressure goes beyond 10, you can start a combination of dorzolamide and timolol to improve the success of AGV. And so I think it has become now a routine. If the pressure goes beyond 10, 12, you can start with anti-glaucoma drops for a few weeks till your pressure comes down. So to summarize, proper patient selection, whether a very good preoperative assessment, looking for the extent of the PAS and the lens status, meticulous technique, some modifications of the technique on the table, and anticipation and timely management of complications is the key to improve success of AGVs. Thank you.
Thank you, Dr. Suneeta. Any questions from the audience? Yes?
I would ask you, how do you, like any tip or trick to trim or size your tube?
Any
Tips or tricks to trim and size your tube?
How do you
like size your tube? Because
the size of the
it's
tube.
not always possible to, cut it at 2 or 3 mm. How do you like?
See, it is, sometimes it happens that you cut it little longer, and ideally it should be done, because sometimes, especially if the patient is having PAS, then it may not be possible to introduce the tube through the same, entry. So I always make it longer to begin with, and if it goes easily, then you can just remove it, inject little bit of visco, and then reinsert it. So it is always advisable to keep the tube little longer to begin with, and then remove it and cut it.
So ma'am,
to the size.
if you aim for 3 mm, you probably would cut it at 4 or 5 mm?
4 and 5 mm, and then if you are satisfied with the position of the tube, then you can just remove it and reinsert it after cutting it to the desirable length.
Thank you,
ma'am. Actually, ma'am, I just want to ask 3 questions regarding your presentation. The first question is, can we use fibrin glue to attach the sclera?
You can use fibrin glue also, although it is expensive.
Yeah.
So unless it is needed, if the conjunctiva is not very good, it is already fibrous, or it is very friable, or if it is short, then it's a very good way to reposition the conjunctiva to make it. Otherwise, if conjunctiva is good, then unnecessarily, like, it is just increasing the expenditure, but you can use it.
Okay. Actually, my second question is, what is the chance of endophthalmitis if we present the tube inside the vitreous beside the sulcus? What is the chance of future endophthalmitis? Because the vitreous cavity is being opened to the subconjunctival space. So if the chance of what is the chance of
you are putting sulcus or in the vitreous?
In the vitreous.
In the vitreous, you will insert the tube in vitreous only when you have removed the vitreous.
Yeah.
Because you can't
After vitrectomy.
otherwise put. So when you have already removed the vitreous, the chances of endophthalmitis, I don't think will increase. The
Okay.
chances of endophthalmitis are less when you have already, in a vitrectomized eye, the chances of endophthalmitis are slightly low
Decreased.
as compared to the eye with a normal eye. But at the end of the surgery, you have to make sure that it's not leaking from anywhere.
Okay.
The site from where you have injected the tube is sealed properly, and you have sutured that port also if it is leaking. Especially if there is low scleral rigidity, then there are chances that the eye becomes hypotenuse. So I think you need to make sure that at the end of the surgery, the AC is well formed, the pressure is normal. And sometimes I I inject Helon at the end of surgery to make it the pressure normal.
Okay.
Because post-operatively also, especially in valved implant, there are chances that the aqueous will drain out of the tube. So it is always better to put some Helon, which is very less non-reactive type of substance.
My third question is, ma'am, what is the, if I find a patient with peripheral anterior synechia 360 degree, shall we go for a PI first?
PI.
Yeah.
Yeah, if the patient is phakic,
Yeah.
and you don't have an option to put it in the sulcus, or you don't want to put it in the vitreous, then you can make a PI, maybe on the table also,
Yeah.
and then you can insert the tube through that PI also. So part of the tube, the tube will go through the PI, and then it will come to lie on the iris. So the contact, the site of contact with the tube will be very less.
So the PI will be helpful.
Yeah, it
That
will
is
be
it,
helpful.
according to.
Yeah.
Thank you, ma'am.
One question that I had was, if you had a choice between cornea and sclera, I mean, what would you prefer as a patch?
Now it is said that the cornea is cosmetically more acceptable because you don't see it through the
Yeah.
conjunctiva. So one can use cornea. Normally what I do is, as you could have seen here also, that because we have that corneoscleral rim, so I take a part of cornea anteriorly and a sclera posteriorly. So anteriorly it is cornea which is not seen, like through the conjunctiva, and then the sclera is
Dr.
also.
Pandav?
Yeah, I think excellent videos, and you seem to have a preference for putting tube into the sulcus.
Sulcus, yeah.
Yeah, so why do you do that? And do you always put in the sulcus? Or?
No, not always. If the patient is pseudophakic, and if the pupil is dilated, because most of the patients which we do is complicated glaucomas, neovascular glaucoma, the post-PK glaucoma where pupil is dilated, there's a lot of space between the iris and the lens. So there you get enough space to put the tube, and the tube will slip in very easily, and the chances of tube corneal
I think
contact
that's
is
the main
minimal.
thing.
So I prefer,
Yeah,
if
I think that's the
possible,
main thing.
I prefer
I don't
sulcus
know.
placement.
The sulcus
if possible.
versus the anterior chamber, what would
Yeah.
you prefer?
Pseudophakics, probably. I mean, depending on the anterior chamber, of course. But I must be a bad surgeon. I always have trouble with inserting the tube.
In
It
sulcus?
never goes where I want it to. So even if I plan,
Maybe I have
it
done
should be in the
so many
anterior
sulcus that
somehow.
it invariably goes in sulcus
Goes
only
in,
from
yeah,
in my hand.
Yeah, exactly. And
Yeah.
sometimes a peripheral anterior synechia, even if on gonioscopy, is not so evident, but somehow it just loves the iris and it, sort of pushes it in. So any tips to give me for that? I always
Anyone from
seem
the
to-
audience, sulcus versus anterior chamber placement, if you had a choice, would you, yeah. Yes. Yes, absolutely. Absolutely, yeah, absolutely. I mean, if you could see the tip of the tube, and you are sure that you can see the tip of the tube post-operatively, I think a sulcus placement would always be better because it's much far away from the endothelium, and especially so works in children. I mean, you don't want a tube in the anterior.
It's a very safe place
Yeah,
between the
absolutely.
IOL and
Absolutely,
the
I agree.
iris.
Yeah. Yeah.
Yeah.
Yeah. Yeah.
Yeah.
Yeah. Yeah. Yeah, and the other important thing for sulcus placement is it has to be a pseudo-phakic eye.
Pseudo-phakic, yeah,
I mean,
you
you
can't
wouldn't
do a
put it in a phakic
In a
eye.
phakic eye, you can't do it, yeah.
Yeah. Yes, Devang.
Ma'am, I had another question. Your any personal experience with glue?
Glue?
Yeah.
Yeah, I have never done it. The scleral, I have not, used glue for the scleral graft, but I have used it for the conjunctiva, especially when the conjunctiva is not so healthy. So the amniotic membrane and fibrin glue, and to stick the conjunctiva. And the healing of conjunctiva is very good when you use even amniotic membrane over the conjunctiva with the glue.
So, ma'am, weren't any chances of tube exposure, they say, in the early post-op period?
Tube exposure with the glue?
Yeah, because
No,
you're
no.
just using glue. No.
I think in eyes where the conjunctiva is very unhealthy, the tissue glue with amniotic membrane and 1 month of doxycycline. I think this combination works best, and the healing of conjunctiva is very, very good because amniotic membrane facilitates conjunctival healing, and it is antibacterial also. And if you do doxycycline also, I think the same effect, anti-collagenase activity. So I think that combination works very well.
Yeah.